All right, everyone, welcome to our webinar, Impact of Illegal Substances, Viral Infections, COVID-19 Pandemic in Our Pregnant Population. My name is Maxine Henry. I am the co-director for the National Hispanic and Latino Addiction Technology Transfer Center, or ATTC. I will be your host for today's webinar. Before I introduce you to today's guest presenter, here are some brief instructions about today's webinar. This webinar will be recorded and archived for future playback. It will also be dubbed or closed captioned in Portuguese, and join us next week for this event live in Spanish. A copy of today's presentation will also be made available after the webinar. The lines will be muted throughout the presentation so as to minimize background noise and other interference. When we get to the Q&A portion of our webinar, you will have an opportunity to ask questions by clicking the Q&A box, and I will present your questions to our presenter. We will also be asking you to fill out a brief survey at the end of this webinar. The satisfaction evaluation is important to the work we do, and it provides us with the opportunity to improve our training efforts. Although we did not secure continuing education credits for this event, we plan to do so for future events. A certificate of completion can be sent to you upon request via email after the completion of the satisfaction evaluation. Those instructions will come in a separate email. So let's begin. Let us start by introducing the National Hispanic and Latino Addiction Technology Transfer Center and our team. The National Hispanic and Latino ATTC is housed at the National Latino Behavioral Health Association, which is located in New Mexico. NALBA was established to fill a need for a unified national voice for Latino populations in the behavioral health arena and to bring attention to the great disparities that exist in the areas of access, utilization, practice-based research, and adequately trained personnel. Oh, I'm sorry, not next slide. I apologize, Dr. Izquierdo. The mission and goal of the NALBA is to influence behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcomes for Latino populations. In order to meet our objective of providing national leadership on Latino behavioral health concerns, NALBA has chosen 6 major areas of focus: targeted capacity expansion of mental health services for Latinos. Number 2, Latino behavioral health evidence-based practices. Legislation to increase the number of counselors, therapists, and other behavioral health practitioners. Funding for co-occurring disorders of alcohol and substance use. The opioid crisis in the Latino community, and last but not least, suicide prevention. The NALBA's executive director is Fred Sandoval. Our ATTC is part of the ATTC network, which is a multidisciplinary resource for professionals in the addictions treatment and recovery services field. Established in 1993 by the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA, the ATTC network is comprised of 10 domestic regional centers, 2 national focus area centers, and a network coordinating office. Together, the network serves the 50 U.S. states, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and the Pacific Islands of Guam, American Samoa, Palau, the Marshall Islands, Micronesia, and the Marina Islands. Here you will see a map of all of the ATTCs. The National Hispanic and Latino ATTC has a national focus for Hispanic and Latino communities and the workforce that provides services to these communities. The mission of the National Hispanic and Latino ATTC is to provide high-quality training and technical assistance to improve the capacity of the workforce serving Hispanic and Latino communities in behavioral health, treatment, and recovery. We disseminate and support the implementation of evidence-based and promising practices to enhance service delivery, promote the growth of a diverse, culturally competent workforce, and bridge access to quality behavioral health services. We are committed to increase health equity and access to effective, culturally and linguistically grounded approaches. Our ATTC is staffed by Dr. Pierluigi Mancini, our project director. I serve as the project co-director, and Ruth Yanez is our executive administrative assistant. The National Latino Behavioral Health Association is also the home of our sister TTC, the National Hispanic and Latino Prevention Technology Transfer Center. We will be providing contact information at the end of this webinar. Now, my favorite part of the introduction, I'd like to introduce you to our esteemed colleague and presenter for today. Dr. Luis Izquierdo started to pursue training in maternal fetal medicine at the University of New Mexico in 1988. This experience led him to develop the area of expertise in prenatal diagnosis of congenital anomalies. Dr. Izquierdo was promoted to associate professor and tenured at UNM in 1996. After his tenure at UNM, he worked with the University of Florida and the University of Miami. Upon his return to UNM, Dr. Izquierdo was promoted and endowed LB Curate Professorship of Obstetrics and Gynecology, Division of Maternal Fetal Medicine, and has directed the Women's Ultrasound Unit. Well, I am glad that that was so difficult to say because it means that you are doing some amazing work in our community, Dr. Izquierdo. Thank you for testing my ability to pronounce these words. I really do appreciate it. We are so honored to have you here today, Dr. Izquierdo. I want to pass over the presentation to you.
Thank you. I would like to thank the National Hispanic and Latino Addiction Technology Transfer Center and all the staff that has been helping me here, okay? I'm gonna try to be as clear as I can because although I've been 30 years in mainland USA, I have not been able to get rid of my accent. So I will pretty much read whatever is on the slides, but it is important that I have a couple of other issues to mention. So I have the polling question there. Excellent, very good. So everybody knows all this stuff that I'm going to talk about. Now, when we talk about substance use disorders in pregnancy, particularly those that have opioids or involve opioids have become a major public health issue in this country and many other countries. The comprehensive evidence-based guidance for the prevention and management of these disorders during pregnancy is lacking significantly. It's interesting, and you are probably aware of most of this data. The rates of substance use in pregnancy have increased significantly in the past decade, and that rates of opioid use disorders in pregnant and postpartum women have increased in parallel. And you know, that's data that is national. 21%, and I was very surprised about this, but 21% of pregnant women enrolled in Medicaid receive a prescription for opioids. I haven't looked at the third-party payers insurance, but I'm pretty sure it's similar. From 2000 to 2009, antepartum, so before delivery, maternal opiate use increased from 1.19 to 5.63 per thousand births per year. That's a significant increase. 85% of women filled an opioid prescription after a C-section. 4% of pregnant women reported using an illicit substance in the past month prior to delivery. And those are numbers that I'm still in shock that they exist. No? Substance use plays a role in pregnancy-associated deaths. And these are pregnancy-associated deaths are those that occur while pregnant or within 365 days of pregnancy from any cause related to or aggravated by pregnancy. These are incredible numbers that I was not aware of. And in Texas, Maryland, and Alaska, 17, 15, and 22% of pregnancy-associated deaths were attributed to substance use. Now, the Society of Maternal Fetal Medicine, Society of Addiction Medicine, and other groups had a workshop, and I can send you the reference to that workshop later. But basically, their consideration was that all pregnant women should be screened for substance use at the first prenatal visit. Important that biologic testing, when performed, should be undertaken only with the woman's informed consent. Now, this is a very common issue that we have in our settings. For opioid-naive women, non-steroidal anti-inflammatory agents, or NSAIDs, and acetaminophen, unless contraindicated, should be given at the first line treatment for pain after a routine vaginal birth. Same thing applies for cesarean section. So in these patients that deliver, we used to send them home with propoxyphene, with oxycodone and different type of things, but right now the recommendation is to send them just on NSAIDs or acetaminophen, okay? On discharge from the hospital, if an opioid-naive woman requires opioids for persistent pain, she should be counseled about the benefits, risks, alternatives, side effects, and the potential for misuse. If we have to prescribe opioid pills, we have to limit the number of pills that are prescribed to these patients. All pregnant women with opioid use disorders should be offered maintenance therapy with methadone or buprenorphine. Pain management for these patients who are taking opioids for chronic pain or who have an opioid using disorder during pregnancy and during and after delivery involves multidisciplinary approaches that may include an anesthesia consultation. Neuroaxial anesthesia should be encouraged. Neuroaxial anesthesia is spinal anesthesia or epidural anesthesia. Okay, this is probably the most important message of this part, because management of opioid use disorders during pregnancy requires an approach that involves a wide range of healthcare, social, behavioral service to address the complex needs of these patient populations. They propose that there's two models that have been that are available: a collaborative model or a one-stop shop model. And I'll show you what we're doing at University of New Mexico. Given that substance abuse in pregnancy is common, that the consequences of substance misuse are substantial, and the treatment interventions are available, screening pregnant women for drug and alcohol use is warranted. We refer to screening as a universally administered questionnaire designed to ascertain who is at risk for having a substance use disorder, and not as a screening technique. A biological test may be useful only in selected situations. Again, universal biologic testing to screen pregnant women is not recommended at this point. The goal is to identify those women with substance use disorders and to help all such women receive treatment if needed. There's a bunch of screening tests. The one recommended by ACOG is not very good. It has a bunch of limitations, and it's called the drug abuse screening test. What I'm concerned about is that the sensitivity is 47%. What that means is the probability that the test is positive when disease is present is only 47%. So not a very good test. No? The positive predicted value is also very low. So if these are the proportions of patients with a positive test that have disease, very low, not good, okay? Now, another screening test that we use is the 4P+, and these are 5 different questions to the parents. Did either of your parents have a problem with alcohol or drugs? Talk about the peers. Do you have any friends that have problems with alcohol or drugs? Does your partner have a problem with alcohol or drugs? Have you ever been drunk? Or in pregnancy, this is the important part here. In the month before you knew you were pregnant, how many cigarettes did you smoke? How much wine, beer, liquor did you drink? How much marijuana did you smoke? How much medication for pain, anxiety, depression, Valium, oxycontin did you take? Now, so those are important tests. The other test is a CRAFT screening tool, mostly used with adolescents. And these are the initials and what do they mean. The important thing does your family or friends ever tell you that you should cut down on your drinking or drug use? Have you ever gotten in trouble while you're using alcohol or drugs? And this is important because this has a 90% positive predictive value. But that means that 90% chance that the patients that do have disease have a positive test. So that's important to have in common. Now, in 1990, many people, including me, thought that the substance use problem was a disease of poverty. This study was done by Ira Shasnov in 1990, and it was done in Pinellas County in Florida, although he was working at Northwestern University in Chicago. And this what really opened my eyes. He compared, and they tested everybody blindly, okay? All comers, all pregnant patients from public clinic or from private practice, okay? Drugs identified in the urine, whatever, all these drugs here, any of the above. The public clinic, 16%. The private clinic, 13%. There was no statistically significant difference between the private patients and the public clinic patients. And it is important, and his conclusion at that point was that the use of illicit drugs is common among pregnant women, regardless of race and socioeconomic status. If legally mandated reporting is to be free of racial or economic bias, it must be based on objective medical criteria. So I think that's an important study. Keep in mind, this is not a disease of poverty. This is not a disease of the county clinic patients. It is all over, okay? Now, interventions after a positive screening test, it's important that drug treatment services and referral of these patients, and important, like when you are all part of the team, that we have care, collaboration, and support services. Now, who gets biologic testing? Well, a positive response on a self-report screening questionnaire or a woman's history. A decision to offer biologic testing or a pregnant woman must be informed by legal mandates. So here at the university, we have to consent these patients in order to get a biologic test. We focus on when testing is medically appropriate. But the advantages of testing of biologic markers of substance use include objectivity, ability to test multiple substances, and a well-established validity. But remember that biologic tests do not distinguish between occasional and regular use. Other people that should have biologic testing include obtunded or unconscious patients, patient who's falling asleep mid-sentence. I have seen that. We see that here frequently. Patient comes stoned from an outlying clinics, and you probably cannot talk to them until the next day. No prenatal care at the time of delivery, that's a major signal. Patient with recent physical evidence of injection use, track marks. Patient with unexplained soft tissue infections or endocarditis. And I can tell you, we had last year a patient with a bunch of tracts, had an endocarditis. She developed a myocardial infarction, pregnant at 25 weeks. And from that endocarditis, she shot a clot to the brain and became brain dead. And the major question at that point was an ethical question with the family, which was divided in the decision-making. So all these things are very important. In our setting of labor and delivery, in terms of high-risk pregnancies, complications such as placental abruption or unexplained severe high blood pressure that can be caused by cocaine and amphetamines are important clinical clues that these patients need to be tested, okay? Placental abruption is, just to clarify that, is separation of a normal placenta. And what happens is when it separates before delivery, the patient will bleed out and develop other sequelae of bleeding out. Now, their story in New Mexico, this is important. These are drug-related deaths, most of them unintentional. And you see from 2001 to 2017, how they have been steadily increasing. Major concern that I saw of these slides here is the drug overdose death rates by ethnicity. In male, 36% Hispanics, female 16, total 26. And this is data that is worrisome, although this could be numbers that are kind of biased in this state because 40% of our population is Hispanic, okay? But again, we're highly represented in that group. And this is by counties. Those of you familiar with New Mexico, sorry. You know that state of Texas connects in this area here, and that's El Paso, Texas, but down south is the state of Chihuahua and the state of Sonora, Mexico, that are very close to our borders. But interestingly enough, most of the counties that we have affected in our state are in north central New Mexico. Okay, Bernalillo is the area where Albuquerque is, but you can see Rio Arriba, which is a large Hispanic population, Colfax, San Miguel County, which is Las Vegas, New Mexico, Santa Fe County, which is Española, New Mexico. There's a lot of significant problems in those areas. The opioid overdose related visits have increased steadily from 2013. Incredible. So these emergency rooms are going crazy, and they see, although has stabilized a little bit, but still is higher than what was said in that case 4 years before. Again, we are highly represented in opioid overdose related emergency department visits, 66, 41, and 55, okay? So that's a lot, and that's per 100,000. So again, still significant. Now, same thing, same areas, opioid overdose related emergency department visits, Rio Arriba, Taos, Mora, San Miguel, Santa Fe, Bernalillo, Socorro, all this area here is where the high problem of opioid use disorders are in our state. Now, at the University of New Mexico, we created a program called Milagro, Miracle, for those who don't speak Spanish. It was created in 1989 based on a grant funding. And it was the first program of its kind to provide comprehensive prenatal care to all these pregnant patients that were involved in substance use and opioid use disorders. Interestingly enough, the fund, I helped a little bit to write that grant, and we programmed for 15 patients on the first month. At the end of the first month, we had 40 patients enrolled in this program. That was good for us, but we were not expecting that to be a major problem at that point. But right now, it is run through the family medicine and community medicine clinic, and as obstetricians, we help them to provide the outpatient visits. But important is that it's a one-stop clinic. They have medical, nursing, counseling staff, they are frequent follow-up, and they're giving compassionate care before and after pregnancy. Now we're going to the next polling question. Yeah, excellent. You are killing this. You know more than me about this. So it is important that I learn a lot by looking at all this information, but thank you. You did great. Okay. Now, these are the statistics related to hepatitis C virus. It was originally identified in 1989. Important to know that 3% of people worldwide have the virus. 3.9 million Americans are diagnosed yearly. Hepatitis C virus is the most common blood-borne infection in the United States. More concerning is the fact that 50% of the people that have this virus are unaware of it, okay? So it's something to be concerned. We have a major problem in New Mexico with hepatitis C, and I'm gonna give you some clinical stuff that I hate to bore you with, but I think it's important. The chronic hepatitis C virus infection is defined as a reactive antibody, okay, to hepatitis C with detectable hepatitis B ribonucleic acid or RNA for more than 6 months in duration. It's one of the most common chronic liver diseases and accounts for 5 deaths per 1,000 population in the United States of America. The majority of liver transplants performed in the United States are for chronic hepatitis C related liver disease or hepatocellular carcinoma. Important, these hospitals that have a large liver transplants, most of the ones we're gonna see is these. Complications of this virus includes cirrhosis, liver damage, liver failure, and cancer, okay? Hepatocellular carcinoma. How do we get this virus? Well, primarily acquired via infected blood-borne, blood-to-blood contact, but mother-to-infant transmission can occur in about 5% of the time in these patients that are infected at the time of delivery. But I'm going to qualify that later. The transmission occurs from mothers who have a viral load that is significant as opposed to those that have antibodies for hepatitis C, but negative viral loads, okay? And pretty much same things applies to HIV, just to tell you that. Now, modern, but again, risk of transmission is related to the level of virus at the time of birth. Modern to infant transmission is most commonly diagnosed by the presence of antibodies and or RNA in the infant after 18 months of age, but can also be diagnosed by detectable viral loads on 2 occasions, 3 to 4 months apart after the infant is 2 months old. Important co-infection with HIV and high maternal viral load are associated with higher risk of transmission. I don't know in your states, but here in New Mexico, the prevalence of HIV is not that high yet. But again, with the high incidence of hepatitis C that we have, it's something to be concerned. But this is what happens. You either develop a chronic infection or you clear it. Okay, you're stable, chronic infection, 30%. 40% show slow damage to the liver. 30% show rapid damage to the liver. Eventually, what will happen is that they will develop cirrhosis, decompensated cirrhosis, and hepatocellular carcinoma in 1% of these patients. So this is not very good news, okay? Now, important, what are the odds ratio of risk factors if you have hepatitis C infection? Major intravenous drug use, transfusions, sex with an IV drug user, having in jail for more than 3 days, and this is data from the CDC, religious scarification, having been struck or cut with a bloody object, pierced ears and body parts, immunoglobulin injection. So all these things, again, some of them are, you can argue back and forth whether they're good or not, but the major problem here is intravenous drug use, blood transfusion, and sexual contact with positive people. Good. Let me see what happened here. It stopped. Give me 2 seconds. Okay, very good. Important, hepatitis C patients should be screened for co-infection with HIV, hepatitis B, as well as other sexually transmitted diseases or infections. Now we call it infections. We used to call them STDs, now they're called STIs. Yeah, we are here seeing in New Mexico a big growth of syphilis. Okay, the main issue is most of the time they're undiagnosed. Okay, and they come in pregnant. Oh yeah, they tested positive for syphilis, and then we'll have to treat, and probably the baby will get treated and will get a lumbar puncture because the baby could have been infected with a syphilis. A blood test to measure liver function, ASTs, ALTs, bilirubin, platelets, prothrombin are recommended. A strong consideration should be given to liver specialists. Important to measure the viral loads, and these liver specialists will order a hepatitis C genotype for counseling regarding the risk of mother-to-infant transmission. Patients with chronic hepatitis C are at high risk of liver failure if they become infected with other forms of hepatitis. And that is important because it leads us to screen for immunity to hepatitis A and hepatitis B, looking at the surface antibody. Vaccinating, if not immune to hepatitis A or B, is also recommended in hepatitis C patients. Ideally, women in reproductive age with chronic hepatitis C treatment should be done before conception, as short as 8 to 12 weeks before the pregnancy, particularly if they have advanced liver disease, compensated cirrhosis, or severe extrahepatic complications of hepatitis C, or prior children infected with hepatitis C via mother-to-infant transmission. If patients pregnant and have if patients are attempting to get pregnant and they have decompensated cirrhosis, it is not recommended. And in general, these patients don't get pregnant because the placenta, these patients that have cirrhosis cannot get rid of the estrogens, of the hormones, so they do not ovulate. So most of the time, they're not going to get pregnant, but once in a while, we see them, okay? In hepatitis C positive but HIV negative women, cesarean section should be reserved for obstetrical indications, as it does not decrease the risk or rates of vertical transmission of hepatitis C. Breastfeeding is not considered, important, they can breastfeed, it's not considered a risk factor for vertical transmission of hepatitis C in non-HIV, okay? But it is contraindicated in patients that are co-infected, hepatitis C and HIV. Important message for these patients, and you're probably the front line that is gonna see these patients. Treatment for hepatitis C should be considered after delivery in all infected patients. It's very important that we consult the family planning people to make sure these patients don't get pregnant while they're getting that treatment. This is CDC guidelines warranting hepatitis C screening, and pretty much the same thing. I was very concerned about this because most of the today persons that are getting art in the skin or body piercing are going to safe places, but I suspect they refer these as local or prison tattoos that are probably old needles or something that can transmit the virus. I was concerned about that. What about in New Mexico? The numbers of each risk factor in New Mexico pretty much similar, okay, to what I showed you before. Inject non-prescription drugs, use of non-injectable street drugs, blood exposure to sharing needles, contacts with hepatitis C infected person, pretty much the same. Now, we are in a very rural state. You know, Santa Fe, which is the capital of the state, is 60 miles north of Albuquerque. And that puts in perspective all these other towns that have a problem with needles. But New Mexico has created a robust syringe exchange program in these towns to promote safe injecting practices and reduce hepatitis C transmission. All of this has been done with the help of this project called Project ECHO, run through the School of Medicine, and you're probably all aware of these projects, and they're in a bunch of different states. But this was, this was a grant by the Robert Wood Johnson Foundation, and basically uses telementoring to equip primary care practitioners in rural areas with the knowledge they need to provide high quality specialty care. Our project here was created by Dr. Sanjeev Arora, which is a liver disease specialist, but social entrepreneur too. And he recognized that there was a problem, and the project originally started because we had such a big problem with hepatitis C, and there were not enough liver specialists in the state. So he started to work with the communities to deliver best practice training and in specialized medical treatments to primary care providers in rural areas through video conference technology. Again, they also facilitate a wide array of programs in support of mental health disorders, substance abuse, education, and much more. And somewhere here I included the link to their webpage in case you want to further explore this program. They are seeking to address the prevalence of hepatitis C in New Mexico. They engage with the primary care clinicians around the state in order to provide the treatment in underserved populations, okay? The primary care providers participating in this ECHO program are able to present patient information to their peers and then collaboratively develop a plan of treatment based on the recommendations from the specialists that are at the hub. And then after an individualized hepatitis C treatment plan is established for each patient, follow-ups are conducted to present the patient's treatment status, to relay related issues that may impede treatment, and to alter the treatment plan as needed to maximize patients' cure. And this is the link. It's included in your PowerPoint, in your handouts. And let me tell you, that's an awesome staff. They're always available, and they can answer any question that you have. Now, what do we know about this problem? And comes the polling question now. Wow, impressed. So we're all reading about COVID. That's awesome. It is important because every time I open the paper or I open a journal, we have a different opinion of what is going to happen, no? But you, as healthcare providers and mental health care providers, need to understand that COVID virus triggers significant amount of anxiety, and this is at all levels of the population. I had one of my coworkers call me the other day and told me that she couldn't handle it anymore, and she started crying on the phone. And that's terrible because, you know, we're dealing with a big problem, okay? And it's at all levels: medical providers, people, healthcare associate providers, health alliance sciences, not good. But my concern is that this pandemic has led to a lot of poverty, especially in our Latino population, because there are no jobs, okay? And it is important to understand that, okay? Now, from our standpoint, in obstetrics, the problem that we have is that our undocumented citizens are avoiding medical care. Two reasons are possibly the cause of this. The pandemic scares them from attending the clinics and getting infected. Number two, with the current migration policy issues, they are concerned about getting caught in the street by ICE and other migration entities. I encourage you to look in New York Times. It was written about a week and a half ago. And this is an interview they did to the UT Rio Grande Department of Obstetrics and Gynecology. And it's a very good read about why women are afraid to get prenatal care. Okay, we need to stand up for these patients. And back in 2017, I wrote a letter to the editor of the Albuquerque Journal, standing up for the healthcare issues of our undocumented citizens. Unluckily, we haven't done much around this, but you as Latino healthcare providers and advocates need to keep standing up because these patients need medical care. They need to be provided with the right care. Now, important. Back to science. So sorry, enough of the editorial. In March 11th of 2020, World Health Organization declared COVID outbreak a pandemic. And this is when I've been home since March 11th, working from home. In light of this declaration, communication to obstetric care providers about this disease and how best advise pregnant patients has become imperative. The problem is that there has been rapid evolving guidance from the CDC with specific focus on maternal, fetal, and neonatal implications. And believe me, every month this changes, okay? Now, primarily, this virus is spread through person-to-person contact via respiratory droplets, which are relatively heavy, fall from the air before evaporating, and are unlikely to spread more than 6 feet apart. Transmission may also occur via aerosolized droplets that remain suspended in air through contact with contaminated surface, or some people have shown that it can be transmitted via a fecal oral route. I haven't seen much data of that, but that's in the CDC webpage. It is currently unknown if the virus can be spread through semen or vaginal secretions. One important message you need to tell your patients is that asymptomatic, pre-symptomatic, and symptomatic patients have all been shown to spread the virus. And I'm going to show you later some data from first wave of COVID in New York. Prevention measures, as you've been reading for the past 9 months, are of critical importance for preventing the spread of infections. The CDC recommends that all individuals take measures to prevent spread by practice frequent hand washing, social distancing, and wearing a mask or face covering when around others. Face masks and cloth face coverings are critical tools in the fight against the spread of this virus. There's increasing evidence that closed face coverings and face masks help also to prevent individuals with COVID-19 to spread the virus. Masking can also help decrease the chance that an individual will contract the virus. And this is the webpage of the CDC that I go every couple of weeks because they keep changing the thing. But again, those are general points that you need to understand. COVID severity in pregnancy, we go back and forth. And if you read the data of what people were recommended to get the vaccine, pregnancy was not in one of them, but the Society of Maternal Fetal Medicine and the American College of OBGYN are advocating that pregnant patients should be in the first tier of vaccines. But there's not enough data to determine the certainty of pregnant women that are more susceptible to acquiring the virus. Recent reports from CDC and elsewhere suggest that pregnancy is an independent risk factor for COVID-19 disease severity. And the first data that came out of Europe after adjusting for age, presence of underlying medical conditions, and race ethnicity, pregnant women are 1.5 times more likely to be admitted to an ICU compared to non-pregnant patients, and 1.7 times more likely to receive mechanical ventilation. So, yeah, significant numbers. These initial data did not show an increased risk of death in pregnant versus not pregnant patients, okay? Now, if you are interested in reading some stuff, the CDC published a weekly journal called Morbidity and Mortality Weekly Report. And this is published recently, November 6, 2020. Using the National Notifiable Disease Surveillance System, the authors identify women of reproductive age who were hospitalized with laboratory-confirmed symptomatic COVID infection. Pregnancy status was available in 400,000 patients, 35%. And 5% of women who were pregnant were compared with non-pregnant patients. Their findings again demonstrated that pregnant women with COVID are at an increased risk for severe disease, specifically a threefold increased risk for both ICU admission and invasive ventilation compared to non-pregnant patients. Interesting, so again, the pregnant patients are at higher risk. Additional pregnant patients had a 2.4-fold increased risk for needing extracorporeal membrane oxygenation, and 70% increased the risk of death for COVID-19. Now, ECMO, or this is a machine that is basically your lung until your pneumonia or your lung heals. So you have a machine breathing for you. But that's a significant increase, and not many states have this machine available, okay? Well, pretty much everybody now, but not many centers, if I may say correctly. Women with comorbidities, older women, appear to have particularly elevated risk of adverse maternal outcomes. And this is important because we have a lot of type 2 diabetics in our pregnant Latino population and in our pregnant Native American population. It is a problem. They come in very sick, they have hypertension, they have diabetes, boom, they get COVID, not good. They wind up in ICU. Women, and this is one of the conclusions there, women of color, specifically, which I don't agree with that comment, but specifically Latina or Black women, also continue to be disproportionately affected by severe maternal morbidity and mortality. So we are to counsel these patients, please be careful, wear your mask, wash your hands, okay? The CDC now has added pregnancy to its list of high-risk categories, okay? The CDC now recommends that pregnant women be counseled about the potential risk for severe illness from COVID-19 and measures to prevent it. Infection with COVID should be emphasized for pregnant women and their families, specifically masking, distancing, and hand washing. Who should be tested? Well, these recommendations are likely to change frequently, but your clinical judgment, test availability, community spread, and the local policies should be used to decide which patients get tested. Right now, for our labor and delivery unit, we're testing all patients admitted, and most of them come with a negative test prior to the admission. Important, can it be transmitted in utero? We do not know that yet, but the reality is that people that have looked at this virus entry to the cells of the placenta, it is unlikely to infect the placenta through these established mechanisms. And the reason is that in order for the virus to enter the placenta, there's an enzymatic process that does not exist. I'm sorry, I'm getting some messages here. Let me see, I probably ran out. Oh, I'm going too fast. Okay, very good, okay. It is important to emphasize the limitations of the data available. The novel nature of this virus, important. We do not know much. We were not ready for this pandemic, and we're learning over time, okay? The data from virus infections in the first and early second trimester of pregnancy is not available yet. The risk of miscarriage with COVID in the first trimester have not shown any difference with incident infection. As you know, 15% of pregnant patients miscarry, okay? Regardless of age. And the thing is that the rate of miscarriage with this infection has not changed. At this time, we do not have any data describing the risk of the baby having structural anomalies associated with the infections either in the first trimester and the second trimester. The major concern that we're looking at right now is those patients that were exposed to the virus in the first trimester and had a fever. And the problem is when you have a fever in the first trimester, the babies are at risk of having being affected with a neural tube defect, with spina bifida, anencephaly, or all types of neural tube defects. In the second trimester, we do not think the baby is going to be affected because these babies are already formed. They're just growing after the second trimester. But again, it's something that is keep an eye once the data of the virus in the first and second trimester is available. Are these women at risk of preterm birth or stillbirth? Well, CDC reported a preterm delivery rate of 8.9% among 43,000 births and a stillbirth of 3.2% among women with virus infection, both symptomatic and asymptomatic. I'm not worried about this number because the incidence of preterm birth in this country has not changed for the past 60 years. It's around 10%, 11%, and this was 8%. Why are we getting, we haven't done much for this preterm delivery rate, but we have better nurseries. So these babies do have a lot better outcomes, even if this has not changed number-wise. Important, the Society of Maternal Fetal Medicine continues to encourage patients with high-risk conditions to receive necessary prenatal care and any type of surveillance when it's indicated during this pandemic. And this is a busy slide, but for you that are healthcare workers and might be pregnant, the evidence shows that the risk to a healthcare worker can be mitigated with the appropriate use of personal protective equipment. Okay, and you're probably having contact with the patients. A lot of you are doing Zoom consults, but if you're doing one-to-one care with the patient, it is important that you wear protective equipment. And now in our clinic, we're requiring everybody to wear eye shields, okay? Approximately 330,000 healthcare workers are expected to be pregnant or recently postpartum during this pandemic. That's a big number. No available data on pregnant healthcare workers that stratifies risk by exposure, gestation, underlying comorbidities, or socio-demographic risks exists. Pregnant healthcare workers should follow the CDC risk assessment and infection control guidelines for healthcare workers with potential exposure to patients with suspected confirmed COVID virus. While pregnant patients may continue to work, facilities may consider limiting their exposure to patients with confirmed or suspected COVID-19 infection, especially during higher risk procedures. Okay, Important. What do you have? You talk about surgeries, vaginal deliveries, etc., where you're going to spill blood, you're going to have a lot of people breathing and pushing, and it is very important. However, this is the problem. In settings with a higher burden of disease or limited staffing, this may not be feasible. If you're working out in the communities, outlying communities, it's going to be very difficult to make it easier for you to work, okay? These recommendations should also be applied to other healthcare workers considered to be at risk of severe complications of infection, such as older adults, people with chronic medical conditions like heart disease, diabetes, lung disease, and those that are immunocompromised. Some patients that receive chemotherapy for any specific type of cancer, or patients that are taking medications that are immune mediated. Those patients should not be exposed to the virus. Now, this is interesting data. This is data from the first wave of New York City. Women presented to labor and delivery, either for an obstetric indication like labor, or pain, along those things. No? Now, on admission, 148 women of those, everybody was tested, okay? Admitted to labor and delivery. And remember, this is the first wave. 61% of the patients that tested positive were asymptomatic. Okay? 69% of this group remained asymptomatic throughout their delivery hospitalization. So you have close to 70% of these patients that were admitted to labor and delivery that had no symptoms at all and went home without symptoms. But these patients were really spreading the virus, no? So it is important that we are aware that there's a bunch of asymptomatic players around that, and you don't know who they are, okay? 14% of these patients progress to mild COVID, 16% progress to severe COVID, and 0.7% progress to critical COVID infections. Important, okay? Now, are we ready for this second round? You know, all of you healthcare providers that are in the front line are probably exhausted, beaten up, and mentally and physically drained. So you have to be very, very, very careful, and you have to keep going. It's not easy, you know, it's not easy, but we need to keep going. We need to beat this. Now, whoop, I missed this. The vaccines for this condition are the light at the end of the tunnel. But we need to make sure that you, as a front line of healthcare workers, teach our citizens that they need to understand that public health in this country should be a top priority. We are trying very hard to get this done. And as you know, and you may have read, Great Britain yesterday had the first injections of their vaccines. And I think it's very important, okay? We cannot be in denial of this condition. This is a real, real problem. In summary, it is important to learn about COVID-19 to optimize patient care and to teach them, the patients and yourselves, to protect against this virus. It is also, as I told you, this is a rapidly changing landscape, and new information will continue to be updated frequently. In terms of the opioid use disorders, this could be out of control during this pandemic, leading to absenteeism from clinics and reincidence in the illegal use of substances. I was talking to one of my colleagues from the Milagro Clinic, and she's telling me that their numbers have gone down big time. So these patients are either not showing to the clinics or are using illegal substances again, and for whatever reason. But this is a major thing to consider. Okay, and then if they get depressed, they might also use other different type of substances obtained in the street that might not be very helpful to manage these patients during pregnancy. Okay? And with this sharing of needles and this issue with the pandemic, I suspect that the hepatitis C levels will continue to increase. We'll have to look at this data about 1 year from now. But again, these are something for you to keep in your brain in terms of appropriate management of these patients. So I hate to bore you with all this stuff. That's my contact information. You can shoot an email. Most of the time I answer the same day, but sometimes the next day. So don't be discouraged if I don't do immediately. But I'm available. I'm working from home. And I enjoy sharing my data for these different type of things. Thank you very much.
Dr. Izquierdo, I wrote so many notes in the last 45 minutes that I am super excited that we got this information. Thank you so much for sharing, this level of information. I have to tell you that, even working in the behavioral health fields, I haven't seen a whole lot of attention being paid to pregnant women and their children. And so it was so good to see that there is some information gathering going on, and that while we don't know, what the future is going to look like, that we at least are, getting prepared by getting this information. So we have a couple of questions, but we want more. So to our beautiful audience, if you can please start putting your questions in the Q&A box at the bottom portion of your screen. I will ask Dr. Izquierdo as many of them as we can in the time we have left. So I have one question that kind of came up from the beginning of your presentation. Can you explain what it means to be opioid naive?
These are patients that have never used to the opioid medications.
Okay, so it's somebody for the first time getting an opioid.
Correct. And for example, I was having some pain a couple of years ago, and I was given oxycodone. Honestly, I don't know how people pop those things into the mouth, into the system, because I had a terrible time taking those medications. I was having nightmares. I was having a lot of complications out of using those medications. But again, these are patients that are naive. They haven't used any opioids before.
Okay, perfect. Thank you. So the first question that I have in our Q&A box here, I do not want to chop up your name, so I'm going to say the last name only. So it's from last name Al-Amin, and I apologize if I still chopped that up. So the question is the data that you presented disaggregated by local population numbers? Because Blacks are only 3% of the total population and Hispanics are the majority.
Correct. We do not have data available yet from the state. I know that our governor is working hard to collect that, but this is data that most of it has been collected from 4 major centers in the country: New York, Washington State, Seattle, Los Angeles. But the reality is that no, we do not have, in our state, we do not have the data yet. We're working on it, as a matter of fact. So, did I answer that or no?
Yeah, no, you did. I mean, that, like you said, the unfortunate truth is that it's a no, but that, hopefully soon we can have some disaggregated data, so that way we can, get a clearer picture of what the representation looks like. We understand the issues with that. So the next question is from Carmen McKibben. Again, I apologize if I did not get your last name correct. So Carmen would like to know, or first says, I'm seeing a lot of fear and mental health ailments among our Latinas right now due to amplified barriers on finances, immigration, and COVID-19. How are healthcare providers encouraging Latinas to seek perinatal care and mental health support with all of these barriers present?
Yeah, that's a great question. For example, in our clinic, I do a mostly Latina population clinic via Zoom in Santa Fe. And I have a staff that calls them twice before the clinic appointment, calls them like a Monday and calls them like a Wednesday to remind them and to enforce them that they are high-risk patients and they should go to their appointments. Still, there's some patients that don't want to go. They're afraid. And I don't blame them, no, because this is something that is very bad. But in our clinics, that's what we're trying to do. Call, remind the patients you have an appointment. Again, we have it in the state of New Mexico, a fund that even with these patients reach a certain level of poverty, the state funds all their care. So we do not have to worry whether they have Medicaid. We do not have to worry whether it's self-pays or anything along those lines. So I think that our governor has done a very good job with that. So we really try to see all these players as much as we can. And I think the major clue is reminding them, needless to say, a lot of these patients keep changing their phone numbers because they buy those throwaway cell phones. They keep changing them, but we try very hard. And what I have seen also is that in the high-risk pregnancy population, they tend to come more to the visits. The patients that are really not coming are traditional patients, low-risk patients, that are probably the ones that are not attending the clinics as much. But we're ready to look at that data.
Great, thank you. Yeah, I mean, you can only do what you can do, right? But I understand that it would be difficult for those who are potentially, either transient and or just hard to get a hold of even before the pandemic. And likely some of the causes of that difficulty are the barriers that Ms. Carmen outlined in her question.
Yeah.
So thank you.
It is a problem. For example, we have about 10% of our patients come from the Navajo country or the Navajo Nation. And the problem is that sometimes these players, although they are insured by Public Health Service Corps and Medicaid, they don't have access to come to the clinics. And they live 5, 6, 8 of them in the same house. And we have had a major problem with patients from that nation getting infected because they are very close together. That's part of their life, no? So, but again, we try, and believe me that we have a big staff there that does that.
Great, thank you. Marisol Romero asked, are there other programs like the ECHO Institute in other states? Are
Yes.
you aware of any?
I want to say like pretty much every state has an ECHO program. And I have to look that up in their webpage. But a lot of people are doing that. One of the other major state that is doing a lot of work on Project ECHO is Arkansas, because they have a lot of rural communities. But right now, most of the states are having that program. And if you are interested, want to participate, please write a note to Project ECHO. And I used to give talks or conferences in Spanish to the medical school in Honduras. I have done it for Colombia. I have done it for Panama. So, and that's through Project ECHO. So there's a lot of capability that we have not explored yet in this type of programs. But write them a note. I think that's a good question.
Yeah, absolutely. I have seen it. I'm originally from New Mexico, so I became familiar with the ECHO program there. But through the ATTC, I've been trained to do some training for providers on hepatitis C, and the ECHO project is a really big part of that education, especially for individuals who are currently incarcerated. And that's regardless if they're in a rural or an urban setting, just because it creates more access to this level of education and connection with healthcare providers. So thank you for that. And actually in the chat, as you were answering that, Dr. Izquierdo, Daniela Montesino said that in New Jersey, through Rutgers University, they are using Project ECHO. So thank you for sharing that, Daniela.
Daniela, thank you. Yeah, and that's where the Robert Wood Johnson Foundation is, out of New Jersey, no? So I'm glad that they're using it. And probably in New Jersey, what you have is a lot of inner city population that does not have access to medical care. And we have problems all over this country right now, and we need to be in the front lines to help our people to do that.
Yes, thank you. So James Roger Riley asks, do you have any guidance on educating and encouraging clients to consent to receive the vaccines in the future?
I want to say yes. And I know that the Society of Maternal Fetal Medicine came up with a statement recently. I'll send it to Maxine and she can share with you. I have to look that up, but it was published last week for guidance of education and everything. Also probably accessible in the webpage of smfm.org or acog.org. There has to be a bunch of educational material there. But I'll look it up and let me write a note here and make sure I sent you that.
And it was SMFM?
S, M like in mother, F like in father, M like in mother.
.org.
Yeah.
Okay, I just put that in the chat for everyone.
And ACOG is also probably, I promised you the other day, Maxine, to send you that paper a friend of mine wrote about the vaccines. I will, and then if you want to distribute it, perfect.
Absolutely, yeah. Once you send me that paper, when we send the instructions for certificates of completion, we'll make sure that we also send a link to that paper. Thank you, Dr. Izquierdo.
That's going to take a long time to educate the people because we have a lot of people in denial about this vaccine. So I think I agree with the person who asked that question that we need to educate the people.
Absolutely, yes. Okay, so another question. Sometimes women who speak Spanish hesitate to call on their providers or have a hard time finding someone who speaks their language. How can healthcare workers help with language barriers in pregnant women and COVID?
Yeah, well, in our state, we don't have much of that problem because a lot of the Hispanics are able to communicate with these patients. We have a good number of providers also that speak Spanish. And the third way, we use a translator program that if the physician or the provider or the health associate that is talking to these patients are help to translate. For example, when I do ultrasounds, the sonographers are required, if they use a translator, to include in the report the name of the translator and the number of the translator. So we look forward to do that. Again, I know that in other states, you're not going to have that, the capacity of having many Hispanic healthcare workers that can help you with that. But I think the best way to do that is by using translators. And we educate these people as much as you can. And if they have questions, then they send us a message on the electronic medical record to call back the patient.
Great, thank you. So yeah, use of those, translators, interpreters. in the chat, Vicky Reza said that they have a bilingual community worker. Regina Walker said that they use translation in person and via telephone service.
Correct.
They call it the language group and proprio. And I might be, Spanishizing that word, and it might not even be in Spanish, but we have a tendency to do that for sure. So yes, I think that, really integrating interpreters.
Let me tell you, about 3 months ago,
Mhm.
I had a patient that had colon cancer and was pregnant. She was very sick, kind of terminal, basically. And so I kept talking to the patient, blah, 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 and the patient was looking at the ceiling, what the hell's going on here? And she wasn't paying attention to me. She was Native American. And I finally asked one of the family members, I still have an accent. Do you think she's understanding what I'm telling her? No, don't worry. She doesn't speak English. She just speaks Navajo. Man, God, that wasn't a good one. I felt so bad. And important, not many Navajo translators available. The good news is that we have in our hospital also a Native American Affairs office. So these people are very good about getting involved with the patients.
Right. No, great. Yeah. And I think that also goes to speak also about, especially in the Latino community, the use of community health workers, promotoras has been really vital to us, being able to provide really community level, culturally and linguistically responsive services. Have
Yeah.
you seen any interruption in that with COVID? Has there
Not
been
at all.
disruption?
No, people have been very helpful. Everybody's available. No, I haven't seen any interruption.
Great. That's good to hear. That's good to hear.
The only problem with that is that some of them feel they're overworked, and they're probably going to burn out sooner than later. I hope not, but it could happen.
Right, right. So we have
There's
one last, oh, sorry, go ahead, Dr. Izquierdo,
there's
please.
an interesting resource there at that Office of Native American Affairs, and I don't know if Ruth worked with him. Is a person, he was the governor of the Sunni Nation, and he likes to talk about the different social barriers and different situations encountering this Native American group of people. So I think it's something worth to hear, because it's worth hearing, because I think he gives some great talks about that.
Right. Okay. No, that's good to know. And especially because we do know that with the reporting of COVID cases, we know that the Native American community has been hit really hard with, during this pandemic. So it's good to hear that there have been these really, deep connections between the communities to help provide as many services as possible. So along those lines, we have one last question. Dr. Izquierdo, can you speak a little bit more on the Milagro model that you use, particularly on how you get patients connected to behavioral health services through that program?
Yeah, we do have in the county a bunch of local health centers that, when these patients are identified, they're sent to the Milagro Clinic as a referral, and then they engage in the comprehensive prenatal care. The other source of referral that we get locally is from prison patients that they start withdrawing in the prison, and they, I'm, as a matter of fact, I'm 3 months pregnant, and they're sent to the Milagro Clinic. But the reality is that the number is accessible, and you have to refer anybody there, they'll take her. I don't know if I went around that question or not, or.
No, I think you did. And it's probably different for every patient that you work with, right? Depending on their level of need and their access to other resources that
Well, I
are.
will tell you that a significant number of the patients that we get are patients that are placed in prison and withdraw in the prison, and so they send it to us. And then the others are referrals from the local clinics.
Great. And then do you collaborate with other community partners to get access to behavioral health services, substance use disorder
Yes,
services?
absolutely. We have a couple of community players in Santa Fe that do a lot of that work. The clinic is called La Familia. It's a federally funded program. They do a lot of the work for northern New Mexico. And there's a bunch of other clinics here. The reality is that this is a very sad comment, but when patients are known to be pregnant, anybody that is managing these patients do not want to touch them. So they usually look for an alternative to send her to our services or to whatever service they want to send it. But really, oh, she's pregnant. I don't know anything about that. I'm going to send her out to a different clinic. So it is a problem.
Okay, so yeah, then it takes that really kind of deep, community collaboration between partner agencies
Absolutely.
to make sure.
Absolutely.
Makes sense. No, well, and thank you for doing that actually. To know that hesitancy occurs even with professionals. So we actually got one more question that I think people would want to hear an answer to. So if it's okay with you, Dr. Izquierdo. Deborah Bailey said, I work as a counselor in an outpatient MMT clinic. We have a significant Latino population. What is the best way to convey the importance of practicing safety precaution among our participants? And many have expressed fear of taking a vaccine. What should I convey to them about the vaccine?
Yeah. I think the best way, again, is to educate them, especially if you don't have many Spanish speaker healthcare workers that can help you. Use the translating program. And important, use the numbers from the CDC and basically tell them, I do not want to die. Do you want to die? Sometimes you have to, some people that are in denial, you have to tell them that, no? It sounds rough, but the problem is that people are not understanding these people. There's a lot of memes in the internet, how you look after vaccine, and they show you like one of the Smurfs. Some of them show you like Ernie in in Sesame Street and stuff like that. But I think it's education, and I hope that once the vaccine gets closer, and I'm assuming it's going to be by the end of this week, that we will come up with more education material of that, because really a lot of patients are misinformed, and really there have been so much confusion between the CDC and the different entities orienting people about this virus that people really don't know what to do. So it is our job to counsel these people. And again, I hope that we develop decent educational material for them. And again, on the meantime, I'm going to send to Maxine this little manuscript about the vaccine. And if I find any educational issue, I'll send it forward to you guys.
Thank you. Thank you so much.
You have to push it. I mean, it's people, the problem is people tied up to these vaccines that were given by pediatricians, that they talk about babies developing different type of syndromes based on the mercury of the vaccines, which turned out that it wasn't true. But the problem is that people are scared. And, it's scary. It's a scary time.
Absolutely. No, thank you. And I think the education just helps to kind of calm those fears of the unknown. But we want to say thank you so much, Dr. Izquierdo. Can you please move 2 slides forward for me?
Yep. You need this. There you go.
Yes, thank you. So as we wrap up our webinar today, I want to first say, oh, if you could go back one. There you go. Yeah.
Sorry.
I first want to say, it's perfect. Thank you to all of our audience members. Thank you for the amazing questions. And thank you for all that you do for our communities. What you're going to find on this slide is some broader contact information for our parent organization, NALBA, and also our website where you can find all of our previous webinars, any of the other products. Incidentally, we also published a fact sheet, a one-page fact sheet on pregnant women, SUD, and COVID-19. Everything that we offer on our ATTC website is provided in English, Spanish, and Portuguese. So we highly recommend that you all visit our website and share it with others. You can also connect with us on social media. Here you will find the direct contact information for our project director, Dr. Pierluigi Mancini, my contact information, and also Ruth's. Again, one more reminder that we are asking you to please fill out a very short satisfaction evaluation. We do want to hear from you. It does help shape future training opportunities. As soon as this webinar is complete, you will immediately be redirected to the external site to complete the satisfaction evaluation. We do appreciate you all taking a moment to do that. Also, Ruth was kind enough to put the link for the satisfaction evaluation in the chat box. Thank you, gracias, obrigado. Thank you to all of you. Thank you, Dr. Izquierdo.
No,
and we appreciate what you're doing for our families.
Thank you. I'm very happy to be able to do it.
Thank you. Stay safe, everyone. Happy holidays.
You too. Thank you.
Thank you.